Good morning, and I'd like to not thank the Academy, but really thank many of you in the room who have put in a lot of sweat equity to get this issue in front of the Institute, and I'm really delighted to be here this morning to talk about the role of the healthcare provider, which is a little bit of a sobering conversation because we really don't know a whole lot about what healthcare providers ought to be doing. And hopefully the dialogue this morning will stimulate some discussion that can move us a little further down the path. I have nothing to disclose, but I will say that my personal lens is largely framed as a result of work with the American Academy of Pediatrics and the proxy healthcare provider group that I'll be speaking through this morning will be the pediatrician, and I think that will make sense to you as I move through my remarks. So the introduction of bullying as an issue for healthcare providers has largely been embedded in the context of violence as a public health issue. And I picked this editorial from JAMA, which is now a dozen years ago, where Deborah Prothero-Stith and Howard Spivak pointed out the fact that research at that particular time had really not examined the relationship of bullying with the risk for more serious violence. And obviously, since that time, the work of Tonya Nansel and others at the NICHD has really established that relationship over the course of the last decade. But I point this out to really frame that for the healthcare provider, the thinking about bullying has been largely embedded in a more global approach to intentional interpersonal injury violence prevention. And in fact, most of the tools that are beginning to emerge have emerged through that lens. And as a part of that thinking, the American Academy of Pediatrics, as part of its periodic survey process of membership, the AAP, by the way, is a 60,000 member organization of pediatricians, the lion's share of which are office-based practitioners. These are folks who are seeing children on a regular basis in the office setting, and the policy and that is driven by the American Academy of Pediatrics is focused on that, that core group of providers. So as you can see here, pediatricians feel they do have an important role to play in prevention, and most importantly, parents expect that the pediatricians should have a role to play in prevention. Now that suggests that there is a bit of preparation and an ability to play a role, which is an assumption that cannot always be easily made just on the basis of training as a healthcare provider or training as a pediatrician. So one of the first tasks that was undertaken by the Academy in response to this pediatric survey was the development of a policy statement, and the AAP makes every attempt to drive its policy based on available evidence. And I will say, as the principal author for this policy statement, not a whole lot of evidence here to drive the policy, but we focused this particular statement, which was published in 2009, largely on bullying as an emerging topic and one that pediatricians needed to be prepared to address no matter what setting in which they practice. So the question on the table, what's a pediatrician to do? The way that we thought about this and the way that I'd like to present this to you this morning is to think about the role of the healthcare provider in the community context with a focus on awareness and advocacy, and then what actually happens in the practice setting in the office. And I'll talk about the promise of anticipatory guidance. So in terms of education, community-based education, the recommendations you see here that pediatricians should advocate for bullying awareness on the part of those who interact with children on a daily basis, those in the educational setting, parents and kids. This, again, cannot be an assumption that parents and kids understand the dynamic, understand the issue, and certainly one of the roles of a provider who is, in the case of a pediatrician, seeing a family for longitudinal care several times during the course of the first several years of life. This is the reason that I am, again, using the proxy of the pediatrician in terms of the role for a healthcare provider, because those who are involved in child health care are seeing kids on a regular basis, and there are opportunities. And then also the role of health professionals as appropriate messengers, and whatever the media be, that print, electronic, online, there are opportunities for advocacy that healthcare providers ought to be taking advantage of. So in terms of opportunities, this map of the United States, which is from last year, the last Federal Partners in Bullying Prevention conference, shows that the majority of states in the United States, what you see there in that red rust, do not have a specific requirement with regard to educator professional development around bullying. And Asha mentioned a moment ago, I was intrigued at the potential opportunity for this credentialing or some way to codify the way that educators or folks, again, who come into contact with children throughout the course of the day receive some level of education themselves on the issue. Again, we cannot assume that folks, just because they are working with children, have this knowledge. And I cite this as an opportunity because the comment that I most often receive when talking about this issue, particularly in front of policymakers, is, well, what's the fiscal note, Dr. Wright? What is it going to, what's the cost to do this? Well, this is a no to low fiscal note impact, the ability to really have experts, and in this case I'm suggesting that healthcare providers can provide that education to folks in the educational arena, and to make that a requirement. And clearly there's opportunity there. Here locally, just a quick example of an opportunity, and pardon the pun, for health providers to be on the bully pulpit and to leverage their role in the community to highlight the issue. Here, this issue that I highlight here is that the District of Columbia was one of 2 jurisdictions in the United States that did not have any form of anti-bullying legislation on the books. And despite the fact that there had been efforts on the part of advocates to enact the Bullying and Intimidation Prevention Act of 2011, it had not moved with the so this was an effort to bring attention to this to the public, and I would suggest that certainly a role for those who see kids and see the effects of bullying behavior presents as an opportunity to do so. So let's move to the clinical practice level, because this is really the only place where there is any suggestion of evidence that would that has really been published to suggest that a pediatrician or a healthcare provider in an office-based setting can impact this in a way that is positive. The recommendations that were part of the policy statement suggest a working familiarity with Connected Kids. Connected Kids is the American Academy of Pediatrics Violence Prevention Protocol. It is baked into Bright Futures, which is the guidebook for pediatricians who are seeing kids on a regular basis, and really speaks to, in a very prescriptive manner, what ought to happen at each visit, and how that visit should be approached based on the developmental stage of the child and the circumstances with the family. and adherence to Connected Kids speaks to not only screening but counseling, timely treatment, and referral for identified problems, including bullying. And the Connected Kids curriculum was published simultaneous with the policy statement, and we have been rolling out both of these documents to the pediatric community over the course of the last several years. So let me talk a little bit about anticipatory guidance. This is really the cornerstone of what parents should expect when they take their child to the pediatrician, that the pediatrician or the healthcare provider who is charged with the longitudinal health supervision of children ought to be able to address, again, based on the developmental stage, the issues that are pertinent to that stage. They should be child-centered, parent-centered, connected to the community in which the family lives, and with a primary focus on the physical safety of children. And I will stress that the emphasis should not emphasize risk, but really be focused on strength and building resilience and building healthy and pro-socially oriented children. And this is really, again, part and parcel of what every provider who is trained to take care of children and families, this is part of the training, and I think a natural opportunity for investigation. And this is just an example of some of the kinds of tools that have been rolled out. These are some open-ended questions, for instance. So we do a lot of role play with providers around how to talk about this issue with a elementary age school child. And you see here several examples of open-ended questions that can lead to a response as opposed to a closed-ended approach to the issue. And you know, it seems rather elementary, again, pardon the pun, but this is critically important to being able to tease out and actually screen and identify if these behaviors are affecting this particular child. So this is at a very granular level, the kinds of tools that are part of an anticipatory guidance approach at each stage of a child's visit to the pediatrician. Here are also some examples of tools that are part of the curriculum, the Connected Kids curriculum, actual brochures that are available to both the pediatrician and the parents, and in this case around bullying, also to the child. So what's been provided, at least to the pediatric community of healthcare providers, are a set of tools and approach, a way to address the issue in the most common healthcare setting, which is the office-based setting that children will encounter providers in. So the question is, okay, well, what does this mean? Is there any value? What's been assessed with regard to anticipatory guidance and its subsequent effect on children and families? Well, I always am delighted to talk about this particular study. It was published several years ago, but really is the single most important bit of work around anticipatory guidance and bullying. This was an analysis conducted by researchers at the Harborview Injury Prevention Center at the University of Washington, involving an analysis of the National Longitudinal Survey of Youth, where the investigators were able to establish that for preschool children, so the cohort's preschool kids, and they looked at factors related to early cognitive stimulation, such as reading to your child, having meals together with your child, and those behaviors in and of themselves independently and significantly conferred resilience on the kids as they moved into school. Also, the second bullet there, the influence of preschool television viewing was associated in a dose-response manner with the development of bullying behavior in elementary school. So I point these out because these are literally the very independent of whether we're talking about bullying or any other issue. These are, for preschool children, the tenets of anticipatory guidance for a visit in the office setting. And this particular study speaks to them as conferring resilience and is, I think, a promising outcome for the anticipatory guidance approach. With regard to research, what can a pediatrician do? The contribution of data to existing surveillance systems, such as the data set that Susan Limber and colleagues are currently, I guess you heard about that yesterday perhaps, and also participation in practice-based research networks. So with that, I will end and be happy to speak about this further in the discussion.